Hello everyone, my name is Susan Waitimo and this is a poster presentation on amiodarone pulmonary toxicity. Amiodarone is the most common antiarrhythmic medication commonly used for ventricular and supraventricular tachyarrhythmias. It has multiple side effects, with the most severe adverse effect being amiodarone-induced pulmonary toxicity. This is attributed to its large volume of distribution and lipid solubility. It has a prevalence of about 5 to 15%. Our learning objectives for today is I'm going to give a case presentation. I'm also going to discuss the mechanism of injury, clinical presentation, diagnosis and treatment of AIPT, and finally we are going to re-evaluate our case presentation. I'll start with our case. So this is an 86-year-old male with a past medical history of coronary artery disease, heart failure with reduced ejection fraction, status post-cardiac coronization therapy device placement, ventricular tachycardia on amiodarone 200 mg daily for 1 year. He presented with complaints of progressive dyspnea, low-grade fever and productive cough for 1 month duration. On exam, he was afebrile, hypoxemic with saturations of 85% on room air and in moderate respiratory distress. He had perioral cyanosis and bibasilar inspiratory crackles. Investigations revealed a leukocytosis of 17,000. Procal was normal and a slightly elevated CRP of 25. Rheumatologic workup and infectious workup was all negative. Hypoxemia worsened despite empiric treatment with initial antibiotics and diuretics with a PaO2 of 61 millimeters of mercury. Subsequent CTA chest was negative for pulmonary embolism. However, it did reveal extensive ground glass opacities with interstitial thickening. AIPT was considered at this point and amiodarone was discontinued. Methylprednisone at 1 mg per kg was initiated. Subsequently, over the course of the next few weeks, his hypoxemia improved and he was placed on a prolonged prednisone taper. On my right is his CT imaging findings. On the left is his CT chest prior to treatment of AIPT, which shows extensive ground glass opacities, which seem to be worse on the left side with some focal consolidation on the lower bases, and on the right shows his CT chest 1 month post-treatment with steroids, which shows near complete resolution of the ground glass opacities. In conclusion, AIPT can be insidious or rapidly progressive. It is usually based on clinical suspicion and radiographic evidence. There are no confirmatory tests and therefore it is a diagnosis of exclusion. Key features that support a clinical diagnosis include new onset dyspnea, exclusion of lung infection, exclusion of heart failure, new radiographic features, and improvement with withdrawal of amiodarone. PFTs done may reveal a restrictive pattern and a decreased diffusion capacity for carbon monoxide. In the absence of a decline of at least 20% in the DLCO, significant amiodarone toxicity is highly unlikely. BAL usually reveals characteristic foamy macrophages. Management usually stopping amiodarone, supportive treatment, and steroids. In our patient, infectious etiology was ruled out and initial empiric treatment with antibiotics and diuretics was unsuccessful. His worsening hypoxemia and new bilateral ground glass opacities on CT chest raised our suspicion for AIPT. He had significant improvement with discontinuation of amiodarone and initiation of steroids. Currently, he's 5 months since his diagnosis of AIPT, currently off the amiodarone for the past 5 months and has near complete resolution of his hypoxemia, currently only uses oxygen 0.5 liters via nasal cannula at night. Below are my references and I have no financial disclosures at this point. Thank you.